In the next 10 minutes or so, Dr. Mease and I are going to go over 2 cases with you, and then I'll have Dr. Mease start first.
Okay, thanks, April. Let's take a look at our first patient. So this is a woman who came to me when she was 39 and working as in a field of research biology. She had the onset of psoriasis in her late teens, and on several occasions, as I've gotten to know her, she's really unloaded about the emotional impact that had on her. You know, embarrassed about going to the swimming pool, embarrassed about showing her skin to anyone, and having significant itch. She had onset of PsA in her late 20s, about 10 years after she developed psoriasis. And initially it was oligoarticular, just involving the left knee and a few toe joints. But the really troublesome feature was her right heel. And she described to me that when she would come out of the subway in the place where she was in a postdoc, she would have to call a taxi to take her the 3 blocks to her lab. And this is on days that she wasn't wearing an orthopedic boot or using crutches. What a bummer. She was initially treated with NSAIDs and the orthopedic boot that I mentioned, and referred to a rheumatologist who initiated methotrexate therapy. So over the years, she's managed to have a modest, little bit of control with the methotrexate, but it was never really fully helpful. She was at one point on a TNF inhibitor, which helped for a while, but then she lost that effect. And so when she was ultimately came to me soon after going to work in Seattle, she was having episodic flares of arthritis in her fingers, knees, toe joints. She had some one occasional case of uveitis. She was really hobbled, though, by this recurring Achilles enthesitis, which made it difficult for her to be as active as she wanted to be with her toddler at home. So here is a assessment tool we use in the clinic as well as in clinical trials to assess for enthesitis. This is known as the Leeds Enthesitis Index, and we press with a certain amount of pressure at the lateral epicondyle where the tendon is inserting into bone there, the medial condyle of the femur, and the Achilles tendon insertion. And then determine, is this patient painful or not? And oftentimes, if we get an ultrasound of that site, we can see light up where there is increased vascularity, something known as power Doppler, as well as other changes in the tendon insertion that designate a true enthesitis. So going back to the cascade of treatments that we've spoken about before and looking under enthesitis, we can see that we've got a number of choices, including the TNF inhibitor class that she's been on before. And she's also got peripheral arthritis and psoriasis. So it's these drug cascades that we're thinking about as we're thinking about potential next steps for her, since she's feeling inadequately addressed. So let's walk through the evidence for each of these to have benefit for enthesitis. With the PDE4 inhibitor apremilast for the PALIS studies, there was benefit using another enthesitis instrument known as the Maastricht Enthesitis Index. The JAK inhibitors, the other oral type of medication, both tofacitinib and upadacitinib, have shown good results overall in the treatment programs. There's sometimes some warbles where you won't see statistical significance in one trial or another, but overall the results have been positive. And here is data with several different agents, adalimumab, for example, ustekinumab, the IL-12/23 inhibitor, secukinumab in both its 150 and 300 milligram monthly doses, as well as the other IL-17 inhibitor, ixekizumab, and on the far right, guselkumab, which is an IL-23 inhibitor. And we're seeing rates of resolution over the course of the placebo-controlled phase of the trial in slightly over 40% of patients. This is data, more granular detail with secukinumab, showing that separation from placebo at week 16 in both the TNF naive and TNF experienced populations. And then as they continue with secukinumab out to longer time points, we see more and more resolution occurring. This goes back to what I said earlier about enthesitis being a difficult to treat domain, partly because of reduced vascularity and continued microtrauma, but eventually we see this over long periods of time, more complete resolution. And this is the data with guselkumab showing complete resolution. Again, slightly better rates as we look at longer time points. What did our patient do? She looked at the totality of this data, and believe me, she's a scientist, so she was looking in detail at all of the PDFs of the various treatment trials, and she ended up going with secukinumab. She liked that data, that longer term data that showed really almost complete resolution of enthesitis. And she also liked the overall efficacy rates in arthritis, psoriasis, and the relatively good safety profile. So at the 6 month mark after switching to secukinumab, her various domains are well controlled, and she's had no infectious events. April, to you.
Yes, great. Excellent. In the remaining time, I'm going to talk about very quickly a second case, a skin on fire with arthralgia. So this is a patient who had come to me August 1st, 2022. As you can see, he is essentially completely covered, extremely uncomfortable. He has total body erythroderma, and he also reported some chills, very, very pruritic, and complaining of burning sensation on his skin. So his skin really felt like literally on fire. Here are his legs. You see some desquamation diffusely, and he was very unhappy, who would be, right? And then also you notice that his nail, he said that these are not his normal nails. His nails were also abnormal here. And when we did a laboratory workup here, he had a bit of leukocytosis, and some abnormal liver enzymes were elevated, and a number of different other abnormalities. Initially, denies joint pain, but later developed joint pain. And then this is his timeline. I just want to point out, when he presented to me, it was actually August, but he started in March, actually, when he started having this. So imagine living with this rash for so many months. So he was very miserable. He initially got prednisone 60 milligrams every day. And then people tried him on dupilumab. That didn't work. Prednisone was weaned to 40 milligrams, but then he was placed on cyclosporin. He didn't tolerate that due to renal issues, and then put on mycophenolate mofetil. And then he saw a colleague in mine for a lymphoma workup, which was negative. They stopped the dupilumab and then came to our psoriasis clinic. And all right, let's see, what is your diagnosis? So the options are atopic dermatitis, erythrodermic psoriasis with diffuse arthralgia, mycosis fungoides, or secondary syphilis. The answer, 100% of you have gotten it so far, is B, and you would be correct. So this is erythrodermic psoriasis. We biopsied this patient was biopsied. So you see this pretty classic kind of biopsy here of psoriasis, elongation of the reedy ridges, perikeratosis. And so this is what we diagnose him with, erythrodermic psoriasis with diffuse arthralgia. So this is relatively rare, but when it's present, patients are oftentimes acutely ill in the acute form, and they are systemically ill. They can be accompanied with the symptoms of fever, chills, fatigue, dehydration, and so forth. And now another question for the audience, since you did so well. At presentation, the question is, the patient was on prednisone and mycophenolate mofetil. What would your treatment plan include? And so here are the choices: continue current therapy, which is continuing prednisone and mycophenolate mofetil, or start him on TNF inhibitors while weaning the current therapy, or start him on IL-17 inhibitor, or starting him on a PDE4 inhibitor and wean the therapies. So we have actually a number of those choices. I think all of those can be possible choices as per the GRAPPA recommendations. What we did is my goal was to wean him off of prednisone as well as mycophenolate mofetil. So prednisone first and then mycophenolate mofetil. So I started him on IL-17 inhibitor, and then we did monthly checkups. And then here are the biologics on how they act in terms of where they act. And here, secukinumab and ixekizumab are two IL-17 inhibitors that has been around for a very long period of time, and they inhibit IL-17A. And they have both good psoriasis coverage as well as joint coverage. And importantly, they also have data on radiographic progression, of halting the radiographic progression, which is shown in the ixekizumab trials here, and then secukinumab studies here showing the prevention or retardation of the radiographic progression, which is something I think resonates with both dermatologists as well as rheumatologists. With regards to treatment of nail disease, you remember he also had nail disease. Here is a network meta-analysis that have shown that our IL-17 inhibitors are quite good in terms of treating that as well. And here is our 60-year-old man, 3 months follow-up. So you can see he's already a lot better. And he's, what you see here is that the nail disease actually in 3 months, this is an amazing example of half of the nail is better here. And the laboratory workup is also being normalized. Everything, numbers came down, but I still want to wean him off of mycophenolate mofetil. And he wasn't completely better. I could wait, but he really wanted to have some kind of dose as some kind of additional treatment. So I started him on deucravacitinib with the goal of weaning him off of mycophenolate mofetil. And this is him in 6 months. So he was much happier. He had been coming to me with his wife every month, but then at 6-month visit, his wife stopped showing up. And that's when I know that he is feeling great, in that he didn't need his wife there anymore. Not that because of his wife is not there. And as you can see here, legs and the fingers. And then here, just as a comparison, before and after for this man. And then here's before and after. And one of the things I'm most excited about is that he got his hair back. So he was very excited about that.
Wow.
We have just a few questions. I thought we can have a lightning round to address this. So it's in our Q&A here. Number one is that is it possible to have the other way around in terms of having bad psoriatic arthritis first and then get an onset of skin manifestations later? Yes, it is. About 10% of the patients, well, depending on the study, 5 to 10% of the patients may have joint disease first before skin disease. And that's when I get referrals from when they start to get skin disease. Sometimes I get patients referred to my clinic to see, hey, is this psoriasis, to help clinch the diagnosis. And the next question, probably for Dr. Mease.
What about a person who displays severe ulnar deviation of fingertips but is rheumatoid factor negative? So this one actually, let's pretend that they didn't yet have psoriasis and they had bad fingertips, meaning distal interphalangeal joint involvement, were seronegative for rheumatoid factor and did not yet have any skin psoriasis, I'd be really thinking about the possibility that this was psoriatic arthritis. But at the moment, I wouldn't be able to say. I'd probably say undifferentiated inflammatory arthritis, and then I would wait. And it could be a year, 2 years, but then if they develop skin patches, then I'm going to be thinking ultimately that this represents psoriatic arthritis. And the last question we have is a general one about what kind of blood test do we do for rheumatoid arthritis. And for that one, we use rheumatoid factor, CCP antibody, SPED rate, and CRP. Those are the most commonly used blood tests that we will use, although not all patients are going to be seropositive for rheumatoid factor or CCP, and not all patients will have evidence of elevation of acute phase reactants.
Great, wonderful. Thank you very much, Dr. Mease, for a wonderful time. I had a great time as usual with this discussion, and I hope our audience also took away a lot of good pearls from our presentation. And as a reminder for our audience members, please check out the new ppcme.com mobile app, where you can download this QR code below to download the app. And you will discover all sorts of wonderful resources there. And with that, I'm going to turn the podium back to the organizers.